So we were talking about, I'm sorry, the previous session was not the last session. There was an interruption. So this session is going to be the last, inshallah. So trial of vaginal delivery basically means that can we try vaginal delivery after cesarean section? It is written over here, trial of labor after cesarean is the attempt to have a vaginal birth after cesarean section. It is, if it is successful, to lack results in a vaginal birth. Okay, and if it is not successful, you will need an other cesarean delivery. Trial of labor after cesarean section. Basically, that is the meaning of that. A trial of labor after cesarean section is planned attempt to labor by a woman who has previously undergone a cesarean delivery and desires a subsequent vaginal delivery. A vaginal birth after cesarean is a successful trial of labor resulting in a vaginal birth. So uterine surgery history and vaginal birth, low transfer cesarean delivery, horizontal incision. So trial of labor contraindication. Trial of labor is not contraindicated if we give a horizontal incision. Trial of labor is contraindicated if we had a classical cesarean delivery, vertical incision. So if there is one classical C-section, then all the subsequent pregnancies should be C-section. Abdominal myomectomy with uterine entry, cavity entry. Yes, it is contraindicated. And abdominal myomectomy without uterine cavity entry, then no. Then it is not contraindicated. Then you can proceed with that. Short interpregnancy interval. Less short interpregnancy interval. So, yeah. So definition is less than 6 to 18 months from delivery to the next pregnancy. Complications are maternal anemia, preterm pre-labor rupture of membranes, preterm delivery and low birth weight. Illicit drug use in pregnancy. So illicit drug abuse in pregnancy risk factors are adolescent pregnancy, late non-compliant prenatal care, and inadequate pregnancy weight gain. Obstetric complications are spontaneous abortion, preterm birth, preeclampsia, abruptio placenta, fetal growth restriction, and intrauterine fetal demise. Delivery plan for non-viable fetus. So delivery plan for non-viable fetus, fetal diagnosis is acardia, anencephaly, bilateral renal agenesis, holoprosencephaly, intrauterine fetal demise, pulmonary hypoplasia, and thanatropic dwarfism. So if all of these, any of these is present, so the fetus is not viable. So we have to do some management plan, and obstetric management is vaginal delivery, and no fetal monitoring is done. Neonatal management is palliative care if not stillborn, because the child will not survive for long. Then we have acute fatty liver of pregnancy. It develops in third trimester, particularly in the patients with multiple gestations. It is an intrinsic hepatic disease with microvesicular fatty infiltration of hepatocytes secondary to abnormal maternal fetal fatty acid metabolism. The clinical features are hepatic inflammation, epigastric right upper quadrant pain, leukocytosis, and increased aminotransferases, fulminant liver failure, scleral icterus, hyperbilirubinemia, and profound hypoglycemia, disseminated intravascular coagulation, acute kidney injury from the hepatorenal syndrome. Management is maternal stabilization and immediate delivery. The acute fatty liver of pregnancy presents with jaundice, encephalopathy, coagulopathy, and profound hypoglycemia. Acute fatty liver of pregnancy, the clinical features are nausea and vomiting, right upper quadrant epigastric pain, fulminant liver failure. Lab findings include profound hypoglycemia, increased aminotransferases up to 2 to 3 times the upper limit of normal, increased bilirubin, thrombocytopenia, disseminated intravascular coagulopathy, and management is immediate delivery. Acute fatty liver of pregnancy, that is AFLP, and HELP, that is HELP syndrome, hemolysis, elevated liver enzymes, and low platelet syndrome, share many features including hypertension and right upper quadrant pain and elevated transaminases. In contrast to HELP syndrome, which causes indirect hepatocellular injury due to the decreased liver perfusion. Acute fatty liver of pregnancy causes fulminant liver failure due to complete fatty infiltration of hepatocytes. Therefore, patients with acute fatty liver of pregnancy typically have jaundice, encephalopathy, coagulopathy, and profound hypoglycemia. Non-alcoholic fatty liver disease. Definition is hepatic steatosis on imaging or biopsy, exclusion of significant alcohol use, exclusion of other causes of fatty liver. The clinical features are mostly non-alcoholic fatty liver disease. The people are asymptomatic. It is associated with metabolic syndrome, With or without steatohepatitis, AST and ALT ratio will be less than 1 and hyperechoic texture on ultrasound will be seen. Treatment is diet and exercise, and consider bariatric surgery if the BMI is more than 35. Then what is hydrops fatalis? Causes RH immunization can cause it, parvovirus B19 and alpha thalassemia. If it is alpha thalassemia major, like yeah. Then features are ascites, equiescent abdominal fluid, skin edema, skin peeling, polyhydramnios, placental thickening, reflecting intravillous edema, pleural effusion and pericardial effusion. Management is with serial ultrasounds and intrauterine transfusions. So there is a picture of a child with hydrops fatalis. There is skin edema, pleural effusion, pericardial effusion, hepatomegaly, and ascites. Then fetal hydrops, pathogenesis, increased cardiac output demand causing heart failure, increased fluid movement into the interstitial spaces, that is third spacing. The clinical features are pericardial effusion, pleural effusion, ascites, skin edema, placental edema, and polyhydramnios. Etiology is immune, RHD alloimmunization, non-immune like parvovirus B19 infection, fetal aneuploidy, cardiovascular abnormalities, and thalassemias like hemoglobins and BARTs. Then we have alpha thalassemia. Alpha thalassemia, one gene loss, that is AA over A negative, alpha thalassemia minima. They are like asymptomatic silent carriers, so carrier must not get pregnant from another carrier, because in those cases there are chances of development of alpha thalassemia major. I don't think so. I think there will be this condition that will follow in any case. Okay, so but there must be screening. Two gene losses, alpha thalassemia minor, mild microcytic anemia, three gene losses, alpha hemoglobin H disease, that is chronic hemolytic anemia, and four gene losses, it is hydrops fatalis and hemoglobin BARTs. Like there is a clump of gamma chains, four gamma chains clumped together, because fetal hemoglobin is alpha 2 gamma 2, so if there is no alpha chain, so four gamma chains will join together, and they are not they can't carry oxygen, so that is why they result in hydrops fatalis, high output cardiac failure, anasarca, and death in utero. Then we have purulent pericardial effusion. So why did they do this? Can I move it? I think I can. So here you can see that let's keep it here. So early postpartum signs. The early postpartum signs are shivering. Then we have uterus contraction becomes firm and globular with fundus typically 1 to 2 centimeter above or below the umbilicus. The vaginal discharge, normal uterine residua, shedding and blood. It can normally last up to 8 weeks. There can be lochia rubra, which is few days after delivery, and there will be reddish brown discharge. These are early postpartum signs. Then lochia serosa, that is after 3 to 4 days, and it is thin, pink or brown colored, and lochia alba, which is definitely white colored. So after 2 to 3 weeks, white or yellow colored. Okay. Just hold on a second. I'm sorry for the little inconvenience. So we were saying that lochia, we talked about different types of lochia. Now let's see this thing over here. Like this thing. Lochia rubra is the first stage of lochia. It is dark red in color and about 4 days long. Then we have lochia serosa. The second stage, lochia is pinkish in color, about 10 days long. And lochia alba is the third stage. Lochia is whitish in color and about 10 to 14 days long. Okay. Then postpartum period. In the postpartum period, there are transient rigors and chills. Normal findings are transient rigors and chills, peripheral edema, lochia rubra, uterine contraction and involution, breast enlargement. Then we have routine care. Routine care is done by rooming in and lactation support, serial examination for uterine atony and bleeding, perineal care, voiding trial, and pain management. Now here you can see pericardial effusion. So the pericardial queuing etiology is hematogenous or directs intrathoracic spread. The risk factors are immunosuppression, hemodialysis, and recent thoracic surgery or trauma. Organisms which are involved in this are Staphylococcus aureus, most common, Streptococcus pneumonia, Salmonella, and Candida. The clinical features include acute presentation. Patients often appear severely ill. Fever, chills, chest pain, and pleuritic or non-pleuritic can be rapidly fatal. Diagnosis is done with the ECG, that is tachycardia, diffuse ST segment elevation with or without low voltage QRS complexes. Chest X-ray will show enlarged cardiac slough and clear lung fields. Echocardiography will show pericardial queuing, and cytology will show turbid fluid with increased WBCs, neutrophil predominant with increased protein and decreased glucose. Treatment is intravenous antibiotics with pericardial drainage. Okay. So then we have the next thing, that is postpartum fever. So in the postpartum fever, temperature is more than 100.4 degree Fahrenheit after the first 24 hours post delivery. I think it is normal finding, right? They were saying that transient rigors in children, postpartum fever. Okay, so look for signs of endometritis, uterine tenderness, and foul smelling lochia. Postpartum endometritis, most common cause of puerperal fever. Presentation is fever more than 24 hours postpartum, purulent lochia, and uterine tenderness. Diagnosis is neither blood or endometrial cultures are required for diagnosis. Further evaluation is indicated if there is no improvement after 48 hours of antibiotic therapy. Treatment: clindamycin with gentamicin. Continue treatment until patient is afebrile for more than 24 hours. Postpartum endometritis, the risk factors are cesarean delivery, chorioamnionitis, group B streptococcus colonization, prolonged rupture of membranes, and operative vaginal delivery. Okay, nitrogen positive. So, how do we confirm that it is amniotic fluid? That is nitrogen positive when there is burning on microscopy. The clinical features are fever more than 24 hours postpartum, uterine fundal tenderness, and purulent lochia. Etiology is polymicrobial infection, and treatment is clindamycin and gentamicin. Treatment of choice: clindamycin with gentamicin for endometritis, ceftriaxone for pyelonephritis in pregnancy, dicloxacillin for lactational mastitis, penicillin group B streptococcus prophylaxis and syphilis, and vancomycin for breast abscess. Then we have postpartum difficulty in voiding. It is a common occurrence. Patient voids spontaneously but has difficulty in voiding. Okay, causes are suppression of micturition reflex and decrease in bladder tone after regional anesthesia, pudendal nerve palsy from injury, periurethral swelling. If the patient is unable to void, they may require urethral catheterization. Lochia: it is vaginal discharge postpartum. It is due to slow process of endometrial shedding and regeneration. It can be bloody with small clots. Patients should be evaluated for delayed postpartum hemorrhage in the following cases: passage of large blood clots, increased pad counts, for example, saturation of more than one pad per hour or more than two consecutive hours, and signs and symptoms of anemia and acute blood loss. Lochia bleeding can last up to 6 to 8 weeks. Normal postpartum lochia. So lochia rubra, lochia serosa, and lochia alba, we have talked about them. So from birth to 3 to 4 day postpartum, there is lochia rubra. Rubra means red, so it is dark or bright red blood, odor similar to that of menstrual blood, and occasional small clots, quantity decreasing each day. Lochia serosa is 4th postpartum day to 10th or 14th postpartum day. It is serosanguinous, pink, brownish, old blood, quantity gradually decreasing in amount. And then we have lochia alba, 11th postpartum day to 6th week postpartum, white, yellow, creamy and light quantity. So this is rubra and serosa and alba. Postpartum thyroiditis. It is same as silent painless thyroiditis, except this occurs within 12 months of delivery. It is the form of painless autoimmune thyroiditis. It can occur within 12 months of delivery. Presentation can be variable. Hyperthyroid, and hyperthyroid, then hypothyroid. Postpartum thyroiditis. It has hypercholesterolemia due to thyroid effect on the lipid metabolism. Diagnosis: decreased radioactive iodine uptake. Thyroid peroxidase antibody assay will be positive. Management: most patients return to euthyroid state and do not require treatment. Differentials include subacute granulomatous thyroiditis, that is decurrent vein thyroiditis. Patient present with fever and have severely painful and tender goiter. Thyrotoxicosis with normal or increased RAIU, that is radioactive iodine uptake. So that happens in Graves' disease, toxic multinodular goiter, and toxic nodules. Thyrotoxicosis with decreased radioactive iodine uptake, painless silent thyroiditis, subacute or decurrent vein thyroiditis, amiodarone-induced thyroiditis, excessive dose or surreptitious intake of levothyroxine, stroma ovarii, ovarian tumor production, thyroid hormones, iodine-induced and extensive thyroid cancer metastasis. Then types of thyroiditis. These are the following: chronic, painless, and subacute. Haven't we talked about stable before? No, haven't. So the chronic autoimmune thyroiditis, which is also called as Hashimoto thyroiditis, it is a hypothyroid condition, predominantly hypothyroid features, and there will be diffuse goiter. Positive TPO antibody, okay, tissue peroxidase, right? TPO is thyroid peroxidase, I'm sorry. So thyroid peroxidase antibody positive, variable radioiodine uptake. Painless thyroiditis or silent thyroiditis. It is same as postpartum thyroiditis seen within 1 year of delivery. Postpartum painless, get back to normal, unlike Hashimoto, which is hypo for life. Okay. A variant of chronic autoimmune thyroiditis, mild, brief hyperthyroid phase, which is followed by a small, non-tender goiter and spontaneous recovery. The positive TPO antibodies and low radioiodine uptake, and subacute thyroiditis or decurrent vein thyroiditis, likely post-viral inflammatory process, prominent fever and hyperthyroid symptoms, and painful tender goiter, elevated ESR and C-reactive protein, and low radioiodine uptake. Postpartum contraception. In patients who are less than 1 month postpartum, oral contraceptive pills are contraindicated because they increase the risk of thromboembolism and can negatively affect breastfeeding. Copper intrauterine devices are good choices for contraception if there are no other intrauterine device related contraindications present. Progestin only pill can also be used because they don't affect breastfeeding. However, they are less effective. Progestin subdermal implants are very good and reliable contraceptive options. They do not affect breastfeeding and don't have any negative effect on menstrual bleeding. Also, they don't increase the risk of thromboembolism. Postpartum depression, it is a very important topic. So, postpartum blues, depression, and psychosis. Prevalence of postpartum blues is 40 to 80%. Onset, it can be preceded by postpartum pinks, in which the woman is very euphoric. So, onset is 2 to 3 days, resolve within 14 days. Symptoms are mild depression, tearfulness, and irritability. Postpartum depression, prevalence is 8 to 15%. Onset is typically within 4 to 6 weeks and can be up to 1 year. Symptoms are more than 2 weeks of moderate to severe depression, sleep or appetite disturbance, low energy, psychomotor changes, guilt, concentration difficulty, and suicidal ideations. And symptoms include delusions, hallucinations, thought disorganization, and bizarre behavior. Then hypotension as a side effect of epidural. It is caused by blockage of sympathetic nerve fibers that will lead to loss of vascular tone, vasodilation, and venous pooling. Prevention by aggressive IV fluids prior to epidural placement. Treatment is left uterine displacement by positioning patient on the left side, additional IV fluid bolus and vasopressor administration. Complications: high spinal or total spinal. When local anesthesia ascends towards the head, it may happen with intracranial injection or overdose of anesthetics. Signs include hypotension, bradycardia, respiratory difficulty, diaphragmatic paralysis, and cardiopulmonary arrest. Wet tap, leakage of spinal fluid if the device punctured, leads to postural headaches, worse with sitting up, improves with lying down, and there will be no hypotension. Then pregnancy and exercise. 20 to 30 minutes of moderate intensity exercise or most or all days of week on most or all days of week is recommended. Moderate intensity should be able to engage in normal conversation during activity. Patient should stop exercising if the following symptoms develop: vaginal bleeding, leakage of fluid, contractions, or chest pain. Avoid exercise with high risk of blunt trauma or falling. Then pregnancy and exercise. Absolute contraindications: amniotic fluid leak, cervical incompetence, multiple gestation, placenta abruption or previa, premature labor, preeclampsia and gestational hypertension, severe heart or lung disease. Unsafe activities are contact sports like basketball, ice hockey, and soccer. High fall risks like downhill skiing, gymnastics, and horseback riding, scuba diving, and hot yoga. Then melasmas are a skin change that can happen during pregnancy. They look something like this. They are acquired hyperpigmentation disorder that occurs on sun-exposed areas of face due to ultraviolet radiation triggering melanocyte proliferation and pigment deposition in sun-exposed areas. Risk factors are pregnancy. Estrogen and progesterone also stimulate the melanocyte proliferation, darker skin color, thyroid dysfunction, medications like anti-epileptics, and cosmetic use. Presentation: irregularly shaped, hyperpigmented macules, varying color from light to dark brown and ash blue, symmetric centrofacial, mandibular, or malar distribution. Diagnosis is clinical and no further evaluation is required. Management is sun avoidance, broad spectrum sunscreen use. Melasma resolve after pregnancy. Areas that do not resolve can be treated with skin lightening agents and topical retinoids. Then let's talk about osteogenesis imperfecta. The types are mild, type 1, moderate, type 3 and 11, type 3 to 9, and severe is type 2. Type 2 osteogenesis imperfecta, pathophysiology is autosomal dominant and it is a type 1 collagen defect. Ultrasound findings will show multiple fractures, short femur, hypoplastic thoracic cavity, fetal growth restriction, and intrauterine demise. Prognosis is lethal. Placenta accreta. When placental villi attach directly to the myometrium instead of decidua, the risk factor prior C-section, history of dilation and curettage at maternal age more than 35. Diagnosis is antenatal ultrasound, irregularity or absence of placental myometrial interface and interplacental villus lakes. Presentation is placenta that does not detach, and manual extraction leads to severe hemorrhage. Management is antenatally diagnosed cesarean hysterectomy and postnatally diagnosed hysterectomy. So if it is antenatally diagnosed, then we do the cesarean hysterectomy, and if it is postnatally diagnosed, then we do hysterectomy. Rectus abdominis diastasis. Okay, so it is rectus abdominis diastasis. Like diastasis means that a thing that was previously adherent becomes loose. Like suppose two ends, like rectus abdominis was like this is one rectus abdominis and this is second. Both of them were joined together. Now they become lax and there's a diastasis between them. Same was true when we were talking about pubic symphysis diastasis. So as you can see, that is a linea alba and it was muscle aponeurosis. Here we have skin, then subcutaneous tissue. Then after the muscular layer, we have peritoneum, omentum, and intestines. Weakening of linea alba, the fascia that lies between the rectus abdominis muscle and keeps them in close proximity. Risk factors are chronic abdominal stretching, like pregnancy and multiparity, surgical weakness prior to C-section, increased intra-abdominal pressure, that is constipation. Presentation: non-tender midline mass, no associated facial defect, no pain, acute GID symptom, rebound or guarding, or risk of bowel strangulation. Management is observation and reassurance, resolves by itself in postpartum. Abdominal binders are not recommended in pregnancy because they cause external compression on the abdomen and may cause fetal growth restriction. Differentials include hernia, associated facial defect, digital cervical examination. It helps determining the cervical dilation and fetal presentation. Okay. It is usually adequate for determining the fetal presentation. However, it may be insufficient in patients with bulging bag. With a bulging bag, do a transabdominal ultrasound instead. The ultrasound is also indicated before performing amniotomy to avoid umbilical cord prolapse in patients with punic, that is cord first presentation. Okay, so ultrasound is also indicated before performing amniotomy to avoid umbilical cord prolapse. Okay, so here you can see that there is a palpable bulging bag and non-palpable presenting part. Palpable bulging bag, non-palpable presenting part. So it is really adequate for determining fetal presentation. However, it may be insufficient if the patient has, if the presenting part is not palpable and there is a bulging bag which is felt on the on your digit. So then you have to perform transvaginal ultrasound, transabdominal ultrasound. Okay. And embryonic gestation, like it is what? Anembryonic gestation means anembryonic gestation is one of the causes of miscarriage of a pregnancy. A blighted ovum or an embryonic gestation is characterized by normal appearing gestational sac but the absence of an embryo. It likely occurs as a result of early embryonic death, which continued development of trophoblast. So it is missed miscarriage if the fetal demise occurs less than 20 weeks of gestation. Post-dural puncture headache occurs due to the unintentional dural puncture during epidural anesthesia. Headache develops within 72 hours of the procedure. Post-dural puncture headache. The clinical features are after lumbar puncture or neuraxial anesthesia. Positional, worse when upright and improves when supine. There will be neck stiffness, photophobia and diplopia, and hearing loss and tinnitus. Management is typically self-limited and epidural blood patch. Then we have pseudocyesis. Okay, that's a new condition for me. It is a condition in which the woman believes that she is carrying a baby, but in reality she is not pregnant. Due to the psychiatric condition, mechanism it occurs due to somatization of stress, which affects the hypothalamic pituitary ovarian axis and causes early pregnancy symptoms like amenorrhea, breast fullness, morning sickness, and abdominal distension. This leads to non-psychotic patients who believe she is pregnant. She is not psychotic, but she believes that she is pregnant. The belief is so strong that the patient may misinterpret negative home pregnancy test as being positive. Oh, okay. Like even the negative tests, she perceives them as positive. Management is psychiatric evaluation and treatment. Then uterine incarceration. It is a rare disorder during pregnancy. It does not occur postpartum because the uterus becomes progressively smaller and therefore unlikely to become entrapped. Mechanism: as the retroverted uterus enlarges, it becomes trapped under the sacral promontory. Presentation is pelvic pain and urinary retention due to the bladder obstruction. Then we have ulcerative colitis during the pregnancy. Ulcerative colitis worsens in pregnancy due to the placental cytokines that worsen the colonic inflammation. Complications are maternal and fetal. So maternal complications are worsening ulcerative colitis disease activity. I hope it is ulcerative colitis. Yeah, it is ulcerative colitis during pregnancy. So worsening ulcerative colitis disease activity, severe hematochezia, anemia, and toxic megacolon. Fetal complications can be preterm delivery and small for gestational age. Fertility rates are lower in those with active ulcerative colitis. Management: the usual ulcerative colitis medications, for example, mesalamine, TNF alpha, are considered safe for use during the pregnancy and during breastfeeding. Sulfasalazine is contraindicated during the pregnancy due to insufficient safety data. Appendicitis during pregnancy. So the appendix undergoes cephalad displacement, like it moves upwards by the gravid uterus during pregnancy. This leads to an atypical presentation of pain in the right mid to upper quadrant or flank. So it's very important that because of cephalad displacement, the pain is not in the right lumbar region. It is neither on the McBurney point. It is displaced to the right mid to upper quadrant or right flank. Features include signs of intra-abdominal inflammation and peritonitis. There is diffuse abdominal tenderness, involuntary guarding, and rebound tenderness, uterine irritability, uterine contractions, fetal tachycardia due to maternal fever. Due to atypical presentation, pregnant patients often have a delayed diagnosis and increased risk of complications, for example, appendiceal rupture and fetal demise. Management is surgery. Acute appendicitis. The clinical presentation is nausea, vomiting, anorexia. Initially, diffuse abdominal pain and visceral pain. Later, localized right lower quadrant pain and somatic pain, and mild leukocytosis. Examination: there will be McBurney point tenderness, Sauce sign, pain with the right hip extension, obturator sign, which means the pain with the right hip internal rotation, and Robsing sign, which is right lower quadrant pain with left lower quadrant palpation. Diagnosis: the clinical presentation and CT scan on ultrasound. Treatment is surgical appendectomy. Then we have vaginal cuff dehiscence. What? Vaginal cuff dehiscence. At what point? Over here. What kind of vagina is that? Vagina is okay. This is vagina. Uh, I don't know at what level has this section been taken, but It may present after hysterectomy. Okay, so basically there's no uterus. I was looking for a uterus. It presents after hysterectomy with increased watery vaginal discharge from the peritoneal fluid leakage through the defect. So there was supposed to be uterus here, which is removed. So from the defect that was created, if there is leakage of peritoneal fluid, that is called as vaginal cuff dehiscence. Okay. So on speculum, we would look something like this. Oophorectomy during pregnancy, progesterone is released from corpus luteum until 10 weeks of gestation, and after that, it is released from placenta. Hence, patients who have corpus luteum removed through the oophorectomy before 10 weeks should be given supplemental progesterone. Diabetes insipidus during pregnancy. Diabetes insipidus remain undiagnosed because the body often compensates for the water loss with a demand of increased fluid intake and, for example, increased thirst. However, during pregnancy, placentally produced enzymes, for example, the vasopressin, increases ADH breakdown and can worsen the symptoms, thereby unmasking the undiagnosed diabetes insipidus. Some women develop transient diabetes insipidus of pregnancy due to exaggerated response to vasopressin. This phenomenon resolves with delivery but recurs with subsequent pregnancies. Features of diabetes insipidus are low urine specific gravity of less than 1.006 and polyuria, that is 24-hour urine output of more than 3 liters. Polyuria, evaluation of suspected polyuria. Complete 24-hour urine collection. If the urine output is less than 3 liters, it is not true polyuria. Work up causes of urinary frequency. If urine output is more than 3 liters, then polyuria is present. Dilute urine, water diuresis, primary polydipsia, diabetes insipidus. If it is concentrated urine, it is osmotic diuresis, increased solute excretion, glucose, urea, and saline. Bipolar management during pregnancy. Valproate has a bad pregnancy safety profile, hence bipolar patients wishing to get pregnant should be switched to lamotrigine. Lithium is potentially teratogenic because of Epstein's anomaly, which is utilization of right ventricle. Yeah, utilization of right ventricle means both is the heart. So the right tricuspid valve moves downward, and the area that was initially supposed to be right ventricle becomes right atrium. So this is atrialization of right ventricle, but the absolute risk is very low due to rarity of the condition. Hence, the patients with severe bipolar who are stable on lithium can be continued on this medication with close monitoring. However, if a new medication has to be introduced, it is better to start with lamotrigine, which has a lower teratogenicity risk. So if a patient is already using lithium, okay, but if we have to introduce a new medication, then go with lamotrigine. Pregnancy should be delayed for 3 to 6 months to assess for the efficacy of the medication. Sickle cell disease in pregnancy, prenatal care, baseline 24 hours of urine and baseline 24-hour urine for total protein, baseline chemistry panel, serial urine culture, pneumococcal vaccination, folic acid supplementation, aspirin, and serial fetal growth ultrasound. Obstetric complications include spontaneous abortion, preeclampsia and eclampsia, abruptio placenta, and antepartum bleeding. Fetal complications are fetal growth restriction, oligohydramnios, and preterm birth. Acute pain episodes, for example, vaso-occlusive pain crisis due to sickle cell disease, occur more commonly during pregnancy due to following reasons: increased metabolic demands and hypercoagulable state. Acute pain episodes increase during first trimester, especially if there are other precipitating factors like stress, nausea, vomiting, and dehydration. Round ligament pain. This pain may occur due to the ligament being stretched by the gravid uterus during pregnancy. It presents with a sharp pain that radiates to the vagina. Then we have bupivacaine toxicity. So normally epidural analgesia is given with the bupivacaine by injecting it in epidural space. However, sometimes the epidural catheter may be inadvertently inserted into the epidural vasculature, leading to systemic bupivacaine toxicity. Bupivacaine blocks inhibitor neural pathways. So bupivacaine blocks inhibit the neural pathways to cause symptoms of CNS overactivity. What? There is normally epidural analgesia is given with bupivacaine. Okay. Epidural catheter bupivacaine blocks the inhibitor neural pathways to cause CNS overactivity. Okay, that's a new thing for me. I thought that bupivacaine is a anesthetic. So they are saying that it causes CNS overactivity. Presentation. Okay, so it is like we are talking about toxicity. So excessive amount of bupivacaine will block the inhibitor neural pathways, and they will result in CNS toxicity overactivity. So there will be perioral numbness, metallic taste, tinnitus, and generalized tonic-clonic seizures. Cardiovascular sympathetic activation will result in tachycardia and hypertension. Management is with drug cessation, benzodiazepines for seizure control, and supportive care. Acute pancreatitis during pregnancy. Patients need 2 to 3 classic features to be diagnosed. Classic symptoms are severe epigastric pain radiating to the back, increased amylase and lipase, and characteristic image finding. If classical symptoms and amylase lipase levels are positive, there is no need to get a CT scan. So, magnesium sulfate toxicity, hyporeflexia, absent reflexes, and cardiac abnormalities. So this is bupivacaine toxicity, and if we are talking about magnesium sulfate toxicity, why is there an arrow? Okay, magnesium sulfate toxicity it results in hyporeflexia, absent reflexes, and cardiac abnormalities. So magnesium sulfate toxicity, the mnemonic is BURP, that is blood pressure will decrease, urine output will decrease, respiratory rate will decrease, and patellar reflex will be absent. So they are saying that magnesium sulfate is the agent most commonly used for the treatment of eclampsia and prophylaxis of eclampsia in the patients with severe preeclampsia. It is usually given by either the intramuscular or intravenous routes. If magnesium toxicity occurs, stop magnesium sulfate infusion and administer the antidote of calcium gluconate 10 ml of 10% solution slowly intravenously over approximately 10 minutes. Okay, so this is over here the clinical management of hypermagnesemia. 5 to 9 milligram per deciliter is therapeutic. Hypermagnesemia 10 to 15 is going to cause areflexia. If it is 15 to 20, it can cause respiratory arrest. More than 25 can result in cardiac arrest. Then we have triglyceride induced pancreatitis. Increased triglyceride level is a risk factor for development of pancreatitis. So triglyceride level typically rises in third trimester. Increased triglyceride rich lipoprotein production and decreased LPL activity. Diagnosis is lipid panel. Triglyceride level more than 100 milligram per deciliter is required for the diagnosis. It is not 100, it is more than 1000 milligram. So management is insulin is helpful in limiting the fatty acids. So it's not 100, it's 1000. So insulin helpful in limiting the fatty acid release from the adipocytes given if glucose is more than 500 milligram per deciliter. And apheresis is helpful if glucose is less than 500 milligram per deciliter or severe pancreatitis. Triglyceride induced pancreatitis. Risk triglyceride level. If it is less than 500, there is a minimal risk. 500 to 999 mild risk. 1000 to 2000. 1000 to 1999 there is a moderate risk, and more than 2000 high risk. Other factors like pregnancy, alcoholism, obesity, and uncontrolled diabetes. The clinical features include acute epigastric pain radiating to the back, with or without fever, nausea, and vomiting. Elevated serum lipase more than 3 times the upper limit of normal. Management is intravenous fluid hydration and pain control. Glucose more than 500 milligram per deciliter, consider insulin infusion. Glucose less than 500 milligram per deciliter or severe pancreatitis, for example lactic acidosis or hypoglycemia, consider apheresis, therapeutic plasma exchange. Peripartum cardiomyopathy. Features are rapid onset systolic heart failure more than 36 weeks or early puerperium, more than 35 weeks to 5 months postpartum. Peripartum cardiomyopathy. Then we have carpal tunnel syndrome, that last topic. So carpal tunnel syndrome, the risk factors are obesity, pregnancy, diabetes, hypothyroidism because it causes mucopolysaccharides. Hypothyroidism is associated with the accumulation of mucopolysaccharides or fats that cause compression. Then rheumatoid arthritis, end-stage renal disease, and hemodialysis because of accumulation of beta-2 microglobulin. Clinical presentation is pain and paresthesia in the median nerve distribution in the first 3.5 digits. Positive Fallon test and Tinel sign. Severe disease, weakness of thumb, abduction, and opposition, atrophy of the thenar eminence. Confirmatory test is done by nerve conduction studies, wrist splinting, glucocorticoid injection, and surgery for severe refractory symptoms. Provocative tests for the carpal tunnel syndrome are flexion or wrist compression, nerve inside the carpal tunnel, and light tapping elicits tingling sensation. Okay, so this is Fallon test in which both the hands are brought close together, and if there is Pain, so that is parentointestinal test is we do the light tapping and elicits tingling sensation in the distribution of the median nerve. Okay, so this was all about obstetrics, and we'll meet in gynecology unit next time. Inshallah, until next time, Allah Hafiz, fi amanillah, and take care.